If you break your arm, an X-ray gives you a definitive binary answer. You look at the film, you see the jagged white line, and the diagnosis is black and white.
Right, it's either broken or not broken.
Exactly. It's a visible, indisputable fact. But what happens when you're one of the, 50% of postmenopausal women suffering from really debilitating pelvic pain, and the diagnostic tool used to prove your condition relies almost entirely on a single doctor's subjective eyesight?
Yeah, that's where it gets complicated.
Today, we are stepping into a diagnostic landscape that is incredibly murky.
Which is tough because we prefer medical science to feel like engineering, you know?
Yeah.
Where you can measure a problem with a physical ruler and get a clean, hard number.
Oh, for sure.
But in the realm of women's health, particularly after menopause, that purely objective ruler doesn't always exist.
Which brings us to our mission for today's deep dive. We're looking at a stack of really fascinating clinical trials, medical reviews, and protocols, including some heavy data from the International Journal of Innovative Technologies and Social Science.
Oh, there is some fantastic data in there.
Yeah, it's dense, but our goal is to understand a crucial yet surprisingly controversial medical metric called the Vaginal Health Index, or the VHI.
The VHI, right.
We want to figure out exactly what this score is, how clinicians use it to grade the severity of vaginal atrophy, and why this little-known scale is the ultimate gatekeeper for treating a hidden epidemic. Okay, let's unpack this.
That's good.
Before we can evaluate the ruler itself, we have to understand the underlying terrain it's actually measuring. What exactly is happening in the body that requires this specific index in the first place?
Well, the underlying condition we're talking about is genitourinary syndrome of menopause, abbreviated as GSM.
Right. And if you look at older medical literature, you'll see it referred to as vulvovaginal atrophy, or VVA.
Yes.
I actually noticed that VVA acronym heavily in the older source material. Is there a clinical reason the medical community shifted to calling it GSM?
There is, actually. The term vulvovaginal atrophy was, frankly, holding back treatment.
Really? How so?
Well, not only does the word atrophy carry this heavy, somewhat stigmatizing connotation that made patients hesitant to even bring it up with their doctors.
Yeah, nobody wants to hear that something is atrophying.
Right, exactly. But it was also anatomically incomplete. So in 2014, major medical societies introduced GSM because the condition doesn't just affect the vagina.
Oh, right.
The estrogen receptors are spread throughout the vulva, the urethra, and the bladder. So when estrogen levels drop, that entire interconnected urogenital system suffers.
So estrogen is essentially the master key to this entire anatomical region.
It is the foundational fuel. Estrogen is profoundly vasoactive.
Vasoactive meaning it affects the blood vessels.
Yes, meaning it commands the blood vessels in the pelvic region to stay open and robust. That blood flow delivers oxygen and nutrients, which, stimulates the production of collagen and elastin fibers.
Yeah.
It also commands the epithelial cells, the skin cells lining the vagina, to secrete mucin, keeping the tissue hydrated and plump.
And reading through the biology of this, the really brilliant part is what those plump cells do for the local microbiome. They act like a food source, right?
They do. In a healthy, estrogen-rich environment, as those thick, healthy epithelial cells naturally shed and slow off, they release a complex sugar called glycogen.
Okay, glycogen.
Yeah, and that glycogen is the primary food source for lactobacillus species, which are the dominant good bacteria in a healthy vaginal microbiome.
So those bacteria basically eat the glycogen and pump out lactic acid as a byproduct, which turns the whole environment highly acidic. It's essentially a self-cleaning, self-defending oven.
An incredibly efficient one. That lactic acid usually keeps the vaginal pH below 4.5.
Which is pretty acidic.
Right.
Huh.
And that high acidity is a hostile environment for dangerous pathogens. It acts as a natural, invisible shield against infections.
But then menopause hits. The ovaries stop producing high levels of estrogen, and that entire microscopic assembly line just shuts down.
The collapse is comprehensive. Without estrogen to command the blood vessels, the blood supply shrinks. And without blood flow, the tissue loses its collagen and its ability to hold moisture. It becomes paper thin. Those cells stop producing glycogen, which starves the lactobacillus.
And without the good bacteria producing lactic acid, the pH level rises.
Exactly.
And once that environment becomes alkaline, it's just open season for invasive bacteria, isn't it?
It really is. Enteric bacteria, so bacteria that naturally live in the gut, suddenly find the alkaline vagina a very hospitable place to colonize.
Oh, man.
Which then travels up the urethra and leads to relentless, recurrent urinary tract infections.
It makes me think of an ecosystem shift.
Yeah.
Imagine a lush, highly regulated, self-sustaining
I
rainforest.
like that analogy.
But then you slowly deprive it of rain,
Mm-hmm.
the estrogen. Over time, the soil dries up, the native plants die off, invasive weeds take over, and it turns into a fragile, cracked desert.
And that biological desertification has a devastating real-world impact. Women are dealing with intense vaginal dryness, the constant burning of dysuria every time they use the bathroom.
Which is incredibly painful.
Yes. And dyspareunia, which makes sexual intercourse excruciating. And this frequently leads to a severe secondary psychological and physical condition called vaginismus.
Where the body just involuntarily braces for impact, right?
Precisely. The brain anticipates the sheer agony of friction on that paper-thin tissue, so it involuntarily contracts the pelvic floor muscles.
Basically slamming the door shut.
Yeah. This leads to a steep drop in libido, profound intimacy issues, and, understandably, significant depressive symptoms.
And yet, despite how agonizing this reality is, our sources note a staggering lack of intervention. Because it happens as women age, society, and sometimes even the patients themselves, dismisses this severe pain as just a natural part of aging.
Which is tragic.
Only about a quarter of women actually seek a medical consultation for this.
It's an epidemic of silent suffering. And unlike hot flashes, which eventually subside for most women, GSM is progressive.
It doesn't just go away.
No, it does not resolve spontaneously. Without intervention, the tissue simply continues to degrade.
Which brings us to the core challenge. If a woman does brave the stigma and sits in her doctor's office, and she's part of the 50% of postmenopausal women experiencing this, how do doctors actually quantify a desert?
Right, how do you measure it?
Yeah, how do they track if a treatment is working rather than just asking her, hey, does it hurt less today?
Well, because clinical trials require hard data to prove efficacy, researchers needed a standardized scoring system. That need led to the development of the Vaginal Health Index, or VHI.
First described by Dr. Gloria Bachman in 1995.
Correct. It is an investigator-assessed scoring tool used directly during a physical pelvic speculum exam.
And it grades the tissue on a 5-point scale across 5 very specific parameters, right? A score of 1 means the tissue is in absolute distress, and a 5 means the tissue is thriving and healthy.
Let's group these to understand what the clinician is actually looking for. The first 2 parameters evaluate the physical architecture of the tissue.
Okay.
So that's overall elasticity and mucosal epithelial integrity.
For elasticity, the doctor is physically feeling how much stretch and give the vaginal wall has. A score of 5 means excellent flexibility, but a score of 1 means the tissue has become completely rigid and inflexible.
And that ties directly into mucosal epithelial integrity, which measures how fragile the tissue has become. A healthy score of 5 means the mucosa is robust and doesn't tear or bleed when touched.
But as the score drops, the friability, the tendency to bleed, increases dramatically.
Yes.
The criteria for a score of 1 here is just shocking. The clinical text says, petechiae noted before contact. Petechiae are those tiny pinpoint bleeding spots under the skin, right? Like broken capillaries.
They are indicators of profound capillary fragility. If a clinician gives a score of 1 for integrity, it means the tissue is so starved of estrogen, so paper-thin, that it is literally bleeding beneath the surface before the doctor even inserts the speculum.
Just the ambient environment is enough to cause microhemorrhages.
Exactly. It underscores how impossible physical intimacy would be for that patient.
Okay, so that's the physical structure. The next 2 parameters evaluate the environment moisture and fluid secretion volume.
Right.
Now, moisture is fairly straightforward, ranging from normal coating to absolute zero moisture where the surface is visibly inflamed. But fluid secretion has some specific jargon.
It does.
The sources say a healthy score of 5 is characterized by normal white flocculent fluid.
Flocculent? That sounds like a type of cloud. What are we actually looking at here?
It basically means the fluid has a loosely clumped, almost wool-like or fleck-like texture. In a clinical setting, a score of 5 means there is enough of this healthy secretion to fully saturate a cotton tip applicator.
Whereas a score of 1 means the vaginal vault is completely bone dry. No pooling of secretions whatsoever.
Which brings us to the final parameter, the chemical environment, the pH level. What's fascinating here is how the scoring is inverted relative to the actual pH number you read on the test strip. Oh, let's make sure this is crystal clear for you listening, because it definitely tripped me up at first.
Yeah.
We established earlier that a low pH number means the environment is highly acidic, which is the healthy state.
Right. Therefore, a low pH earns the highest VHI score. To get a perfect 5 in this category, the patient's vaginal pH must be 4.6 or below. The rainforest is thriving.
But if the lactobacillus die off and the pH rises into alkaline territory, say 6.1 or higher, That earns the lowest possible score, a 1.
So the clinician evaluates those 5 categories: elasticity, integrity, moisture, fluid volume, and pH. Each gets a score from 1 to 5, meaning the total VHI score ranges from 5 to 25.
And there is a magic threshold that acts as the tripwire for a diagnosis.
Mm.
If a patient's total score drops below 15, that is the official clinical cutoff.
Yes.
The doctor has objective confirmation of genitourinary syndrome of menopause.
A score under 15 confirms the ecosystem has collapsed.
Okay, on paper, this sounds like a brilliant, mathematically sound system. You assess 5 things, you add up the numbers, you get a definitive diagnosis. But looking at the actual mechanics of the exam, I have a massive pushback on this.
Let's hear it.
4 of those 5 metrics rely entirely on a human being looking at and touching tissue. Aside from the pH strip, which turns a specific color and gives you a hard number, how on earth does a doctor objectively measure the difference between fair elasticity and poor elasticity?
It's tough.
It feels like a glorified guessing game based on how hard they happen to press the speculum that day, or what they personally consider a moderate amount of moisture.
Your skepticism is entirely warranted, and multiple papers in our source stack highlight this exact subjective blind spot.
I knew it.
Yeah, the VHI is heavily criticized for lacking strict, uniform examination instructions.
So if I go to Dr. A on Tuesday, they might press firmly and give me an elasticity score that results in a total VHI of 14. But if I see Dr. B on Wednesday, they might be gentler and score me a 16, completely changing whether I officially meet the threshold for atrophy.
In clinical research, this is called inter-observer variability, so differences between 2 different doctors. There's also intra-observer variability, which is when the same doctor evaluates you differently from one week to the next.
Wow.
Because the visual cues rely on individual interpretation, some researchers seriously question whether the VHI can be treated as a purely objective scientific tool.
Here's where it gets really interesting. I went down a rabbit hole reading about Dr. Murray Friedman's research mentioned in our sources.
Oh, yes.
He essentially argues that because human eyesight is subjective, the pH level is the only anchor of reality we have in this entire index.
The pH test completely strips away the human error. Friedman's 2018 unpublished data highlights a stunning biochemical correlation.
Tell us about it.
He brought postmenopausal patients in, evaluated them visually for atrophy, checked their vaginal pH, and then used mass spectrometry to assay their serum estradiol, their blood estrogen levels.
Mass spectrometry, just briefly, is essentially weighing molecules with insane precision to count exactly how much estrogen is floating in the blood.
It is the gold standard for measuring hormones.
Oh.
And the results were undeniable. Every single patient who had a severely low serum estradiol level under 10 picograms per milliliter also had a vaginal pH greater than 5.5, accompanied by severe physical atrophy.
And on the flip side, women whose blood estrogen was still above 20 picograms had healthy pH levels and no significant structural damage.
Right.
The pH strip perfectly predicts the loss of the cells, the visual damage, and the pain.
Yeah.
It's basically carrying the weight of the entire index.
It is the one data point that cannot be skewed by human opinion. But
Right.
even with that chemical certainty, the VHI still has a profound limitation. It only measures what the doctor observes, not what the patient actually experiences. A woman might have a borderline VHI score of 16 but experience agonizing pain during intercourse.
Right.
Another might score an atrophic 12 but feel relatively fine in her day-to-day life.
So if the VHI is deaf to the patient's actual pain, how do clinical trials account for her quality of life?
If we connect this to the bigger picture, researchers never use the VHI in a vacuum. To balance the visual exam, modern trials use a comprehensive diagnostic toolkit. They pair the VHI with the visual analog scale, the VAS.
That's the classic 0-10 pain scale where the patient ranks their own suffering, right?
Exactly. Along with the Female Sexual Function Index, or FSFI, this is a robust 19-item questionnaire that measures the real-world impact of the desertification across 6 domains of a woman's life.
Like what?
Desire, arousal, lubrication, orgasm, satisfaction, and pain.
Because fixing the tissue doesn't matter if you haven't restored her ability to enjoy intimacy without fear.
Furthermore, to get past the subjectivity of the naked eye, trials utilize the Vaginal Maturation Index, the VMI. The clinician takes a physical swab from the vaginal wall, sends it to a lab, and looks at the cells under a microscope.
They are calculating the ratio of parabasal cells to superficial cells. But what does that actually tell them?
Paravasal cells are the deep, immature skin cells that usually live at the very bottom of the tissue layer. Superficial cells are the thick, mature cells at the surface.
Okay, so layers.
Right. If a clinician swabs the surface and sees a high number of parabasal cells, it means the top protective layers have completely eroded away. The tissue is literally losing its armor.
Okay, so a patient goes through this battery of tests, the visual VHI, the pH swab, the pain scales, the microscopic VMI. How does this gauntlet actually benefit them? Like, what is the practical application of scoring a 12 versus a 20?
The primary application is accountability. When a pharmaceutical company or a medical device manufacturer claims they have a new cure for GSM, the VHI is the benchmark the FDA and clinical bodies use to force them to prove it.
Ah, I see.
They have to prove they aren't just masking the pain, but actually reversing the physiological desertification and bringing the rainforest back.
And our sources show the VHI validating some incredible interventions. For decades, the gold standard has been local estrogen therapy, LAT.
Right, very common.
Applying a low-dose estrogen cream or inserting an estrogen ring directly into the vagina raises the VHI score rapidly, lowering the pH and thickening the armor without flooding the rest of the body with hormones.
But many women cannot take any form of estrogen, such as breast cancer survivors whose tumors were estrogen receptor positive.
Which is a huge population.
Exactly. For them, the VHI is critical for tracking non-hormonal options, like polycarbophil-based moisturizers, such as Replens, which bind to the epithelial cells and deliver moisture over several days.
But the most fascinating frontier to me in these trials involves the energy-based devices. They're using CO2 lasers and YAG lasers, as well as platelet-rich plasma injections directly into the vaginal canal.
The mechanism behind those lasers is brilliant. It relies on controlled microtrauma.
Microtrauma.
Yes, they laser ablates, or vaporizes, microscopic collars of tissue in the vaginal mucosa.
It's like microneedling for the face, but for the pelvic floor. You intentionally cause a tiny injury to trick the body into sending emergency supplies to an area it had abandoned.
The localized trauma triggers the body's natural healing cascade. Fibroblasts, which are the cells that synthesize the structural framework of tissues, they get activated.
Okay.
They start pumping out new collagen and elastin. More importantly, it triggers angiogenesis, which is the formation of entirely new blood vessels.
Restoring the supply lines. And we know this actually works because the VHI proves it.
It does.
One of the clinical trials tracking CO2 laser treatments over 12 months showed astounding results. The patient started with a mean VHI score of 11.8, severely atrophic, below the cutoff of 15.
Right.
After treatment, that average score skyrocketed to a profoundly healthy 22.5.
That is a near-total restoration of the physical architecture. And predictably, that physical healing correlated directly with massive improvements in their subjective FSFI questionnaires. They got their quality of life back because the tissue had fundamentally rejuvenated.
So what does this all mean? When you zoom out and look at the landscape of postmenopausal health, the Vaginal Health Index is essentially a 5 to 25-point clinical compass.
Yes, a very important compass.
Yes, relying on a doctor's subjective eyesight to grade elasticity and moisture is a flawed method. But when you anchor it with the undeniable chemistry of a pH strip and pair it with microscopic swabs and patient questionnaires, it becomes a powerful tool unlocking an entirely new era of regenerative treatments.
It demands that therapies actually rebuild the tissue environment, holding the medical industry accountable for real healing.
And for you, the listener, understanding clinical scales like this is the ultimate empowerment. If you are experiencing this invisible epidemic, you do not have to accept dyspareunia or chronic UTIs as an inescapable consequence of aging.
Absolutely not.
You can walk into a clinic, specifically ask your doctor to test your vaginal pH, ask them about your mucosal integrity, and demand an informed strategy to restore your ecosystem.
Knowledge gives you the vocabulary to advocate for your own relief. And before we close, I want to offer a final thought for you to explore, building on what Dr. Friedman discovered about the power of the pH score.
The floor is yours.
Since a simple vaginal pH test is so highly predictive of atrophy and flawlessly correlates with severe drops in blood estrogen, it raises a provocative question about the future of gynecological diagnostics. Could we eventually phase out the subjective, physically invasive, and often painful 5-point speculum exam entirely?
Wow, that would be huge.
Could a cheap, simple, at-home pH swab eventually be the only diagnostic key a woman needs to definitively prove she has genitourinary syndrome of menopause, instantly unlocking access to advanced regenerative care without the trauma of the exam chair?
That is a phenomenal question and a future worth striving for. Thank you for diving into the murky waters of medical diagnostics with us. Keep questioning the tools, keep advocating for your health, and keep learning.